If silence speaks volumes, let my life say more than words can express. Inspire to live one's best by following God's steps. You don't have to be rich to show you blessed. Helping your fellow man with your arms outstretched. Changing the world one person at a time. Builds community until our environment inclines. Blessed with vitality, he gives gifts right. So I'm trying to do my best to live a grade A life and be a high grade, next level amazing. That's what we chasing. Amen. Influential with or without ovation for generations. Amen. High grade, next level amazing. That's what we chasing. Amen. Influential with or without ovation for generations.
Only in New York City, we grill in the rain, fellas. Only in New York City.
The blunders, the golden life to be chasing is to strive to be amen. Give back after blessings as if it was payment. Not out of obligation or religion, but out of human nature, it's a given. That's just the way I'm living. Leading with integrity, no matter the price. I'm just trying to do my best to live a grade A life and be a high grade, next level amazing. That's what we chasing. Amen. Influential with or without ovation for generations. Amen. High grade, next level amazing. That's what we chasing. Amen. Influential with or without ovation for generations. Amen. High grade, next level amazing. That's what we chasing. Amen. Influential with or without ovation for generations. Amen. High grade, next level amazing. That's what we chasing. Amen. Influential with or without ovation for generations. Amen.
Good evening, good evening. My name is Michael Adolphus, and this is Amen Ministries, Inc., a wellness webinar series. And on today, I have my good friend, Dr. James Osei Sarpong Jr. How you doing, Doc?
I'm doing well. Good evening, everybody, as well.
Amen. So we have a very good and important topic tonight. But before we get into that, just wanted to say a couple of things. Is that this Friday I'm taking some toys to children in a hospital, and if you would like to donate toys to this event, you can do it by Cash App, PayPal, or Zelle, or you can reach out to me if you want to come. Just give me a call or send an email to the email address on the flyer. I thank you for the considerations of it all. So, Doctor, today's topic is, I got your presentation right here. Today's topic is infertility, hysterectomy, and hysterectomy. So, Doc, without further delay, let's just get into it. Anything you want to say before we begin? And the floor is yours now.
So again, good evening, everybody. Just wanted to talk about today infertility and hysterectomy. So infertility specifically is always like a really big and important topic, especially amongst our communities as well. A lot of questions that we have, or there's a lot of things that we don't know regarding what it is in regards to when there is an inability to have a child or be able to be pregnant. And so hopefully this PowerPoint presentation may give a little bit of information on how this process occurs, what we're looking for when you're getting evaluated for infertility issues, and if you need hysterectomy as well, like what that actually means and what goes into that as well. So next slide.
Okay.
All right. So today we're going to just talk about the first part is going to be infertility. So before we start about what infertility is, I wanted to first discuss how normal fertility works. Next slide. And then next slide again. So in terms of that process, in terms of fertility, it all starts in terms of the reproductive systems, both male and female. Both for the male, we produce sperm, and for the female, on a monthly basis, they usually produce eggs. So during that component of the day, usually on the 28-day menstrual cycle, you'll be producing eggs, which either will, if they meet a sperm, will become an egg, we call a fertilized egg, which can facilitate pregnancy. Or if that doesn't happen, it ends up going into a point where you end up going through the whole process all over again, which is what ends up happening during like the menstruation process. So most pregnancies usually occur during like the first 6 months of conception that is attempted. And usually it comes in, if we explain it in steps, the first part is ovulation. If you've had scenarios where you can tell, oh, you're in a period where you're ovulating, usually like within about the halfway point within the menstruation cycle process. Usually what's going on is that you have just that maturation of the egg that is in the ovary is actually has been released and been preparing for that fertilization process. This is usually within like the first 12 to 24-hour period within that 14-day window that I was telling you about. So day 14 of the menstrual cycle. If there is a scenario where sexual intercourse is had, the sperm end up being released within that process, and in that scenario they end up swimming. Some they go in all directions, but some end up going through the cervix and further up into the uterus or the womb, and then travel to the what we call your fallopian tubes, the tubes that are connected to the ovaries there. So during that process, you also have had your egg from your ovary that had been released and have been traveling probably about like 3 days, to get to the actual fallopian tube itself. It's pretty much a race to who gets there first. So usually there's millions and millions and millions of sperm that are traveling, and whoever actually reaches the egg is able to penetrate through the egg first. What ends up happening is it sends a cascade of events which block all other sperm from being able to enter, and then that genetic material from that sperm travels into the deeper parts of within the egg as well, and then at that point you receive the fertilization. So now the next part after fertilization occurs is that you end up having implementation, which means that now united egg of the sperm and the egg ends up traveling now to the point of the uterus, especially within that lining of the uterus, and ends up implanting itself like there. And in that scenario, that's where it prepares to further develop into what you know as a baby within 9 months' time, eventually. Next slide. So there's some terms in regards to what we talk about when we're discussing about fertility. The first part is what is fertility asking about, or even determining, and it's usually determining your ability to be able to have a clinical pregnancy. This next term that we usually talk about is usually what we call um, fecundity. And fecundity is really just explaining your ability to be able to have a live birth. So having a clinical pregnancy and having a live birth, um, there it's kind of like a square and a quadrilateral, right? So like not all squares are quadrilaterals. Having a live birth, meaning like having a child, is different than being positive for being pregnant. Um, so those are things that are also mentioned as well. The other thing we look at for is the fecundability, which is you're explaining what's your chances, right? What's your probability of being able to achieve a pregnancy, provided all the circumstances are ideal, right? So you have the adequate amount of sperm and there's no contraception involved. And then usually when we deal with a scenario of sterility, this is actually just explaining that there is pretty much a permanent state of infertility and an inability to have the clinical pregnancy. Next slide. So when we define infertility, we're pretty much defining it as the inability for a couple to be able to have or achieve a pregnancy. But the biggest thing that we usually define that clinically or in medicine, we usually define it by a time frame. So usually, if you're in the age range greater than or equal to 35 years of age, usually an attempt or to try to have a child or have a baby or become pregnant within a 12-month period, um, then we would define that as infertility. But if you're less than the age of 35 and you're attempting to be pregnant, usually, um, actually, this is the other way around. Sorry. So yeah, no, this is the right way. So if you're less than 35 years of age, usually it's 12 months before and with the inability of being able to have a child where we would call that infertility. If you're greater than 35, however, and sorry, the slide was it mixed it up. If you're greater than 35 and it's been about like even 6 months, we would say that that's infertility. But both scenarios require that you have the appropriately timed sexual intercourse, and also that there's not like contraception involved as well. Next slide. So now we talk about the causes, right? So from the male side, what are the causes of infertility? From the female side, what are the causes? So generally, the most common causes for men in terms of their contribution of not being able to have a pregnancy is usually more so related to disorder of the sperm itself, its inability to be able to be mobile, or not having enough numbers to accomplish the job. So usually other components and usually also contribute to that as well. If you have like things such as thyroid disease, if you're taking things like anabolic steroids, for a lot of like the those that want to be a big weightlifter, that can affect your ability to have children as well. If you have other conditions as well that are significant, like really big, if you have like a severe liver disease, or if there are things that are congenital, right? That are genetic that are out of your control, and certain syndromes that are associated with uh, certain types of symptoms, but the biggest one being the inability to have kids in a certain manner. And then also the biggest thing that we also look at too is uh, if you have what we call scrotal hypothermia, which is an elevated temperature within the scrotum area, usually sometimes precipitated with injury, infection, or trauma. And the other thing that we look for, and is usually a really big emergency, is we call testicular torsion, where the actual testicle as well as the cord ends up twisting on itself, and it can be such to the degree that the vessels that supply the actual scrotum itself, it's not able to get a blood supply, so that testicle can die. For females, the most prevalent reasons are uh, usually what we call anovulation, so not having an ovulatory period that I was discussing in the previous slides is one of the first stages in order for pregnancy to occur. Um, the other thing is having either absent or even just irregular menstruation in the first place. The other thing that is also involved as well is there are conditions such as endometriosis, which can affect your ability to have children. In this condition, you have pretty much uh, tissue that would normally otherwise be present within the inside of your uterus or the womb, present outside areas of your uterus. So sometimes it could be by the bladder, it could be by the near your colon area, and they can cause a lot of sometimes pain and discomfort, and most importantly, can affect your ability to have kids as well. The last thing that I want to talk about as well is there are genetic components that are controlled, like in terms of if the uterus is built in a is made in a certain way, like abnormally, that can also contribute. In terms of the next slide, so who's usually affected? So usually in the U.S., about like 10 to 15% of couples are usually having trouble with being able to achieve pregnancy and have issues with infertility. Some of the risk factors that are involved is this term is called nulliparity, but it means like is women that haven't had any live birth or child present. So those who haven't, and it's kind of like a common sense related correlation, right? So meaning that if you haven't had haven't had a child, and then you're trying to have a child, it's there it would make sense why, okay, the person who hasn't had a child yet would be in that risk factor group. The other thing that is involved is increasing age. So when I was telling you before regarding the fecundity or the ability to achieve a pregnancy, you notice that within the ages of like 20 to your 20s and 30s, usually your probability is roughly around, say, around 25%. But as you start to get towards the ages of 40 and older, it starts to drop to about 10%. The Between your 20s and 30s, you see slow declines from that 25%, but not too big until it hits around like the 40 region. And then this also is a component that affects all of us as well in various different health aspects. And it's like the access to having reproductive health services in general. It's shown that those who have access to reproductive health services usually have a reduced prevalence or not much of a caseload of infertility issues. And it makes sense, right? The Having the access allows for you to have the appropriate screening, the appropriate follow up in order to have your goals achieved. Next slide. So the question is, and everyone always asks this, either in public or not in public, is they ask whose fault is it, right? So you look at the World Health Organization. They did a survey of around 8,500 infertile couples, and within developed countries. So these would be countries like the United States. And the distribution from that survey showed that about 37% of infertility was attributed to female factor infertility. Some of the causes I had explained in the previous slide. 35% were actually in combination. So both female and male factor infertility was the cause in regards to why they weren't able to achieve pregnancy. 8% were the male factor solely alone for the reason why there were infertility issues, and then 5% couldn't explain. Next slide. So in terms of what I was trying to say is that in terms of whose fault it is really not the important question at all. The both have contributions towards making a goal, which is in terms of you want to have you want to achieve pregnancy and you want to have a live child. And so the biggest thing is not just figuring out who is not necessarily whose fault it is, but it's more so identifying what the barriers are, both in combination and try to see if you can have those relieved so you can achieve a pregnancy. So when we're diagnosing some of these infertility problems, usually it's coupled with us combining not only just what we see from you, say in a visit, looking at both, the medical history, um, some of the patterns of your reproductive cycle, such as like your menstruation, if there's any family history of infertility problems, but also coupling that with diagnostic testing and imaging. Both of the partners are evaluated what we call like together. And in terms of what we look at in regards to history, it definitely involves assessing both aspects of what both the male and the female contribute to the pregnancy. Next slide. So in terms of what we do when we're trying to assess the male factors, the first step that we usually look at after obtaining a history is we try to analyze the actual semen sample. So when the contribution that the male presents with the sperm is usually in a collection of not only just sperm but also a collection of fluids that come from both your prostate gland and also the seminal vesicles as well. And what we do is we analyze it to see not only if it's an adequate sperm count, but also is it the appropriate shape, the actual sperm itself, and is it actually motile? Is it actually and these are the things that are necessary in order for the sperm to get to where they need to go. Next slide. When we're analyzing the female factors, these are a combination again of just obtaining the medical history, such as your menstruation history. When was your the first year you achieved your menstruation? How often are you having your menstruation cycle? What is the process like from a day to day? Are you having any heavy bleeding, any abnormal bleeding in various areas where you've had to use more pads than most? Assessing your ability, the function of whether you're able to have ovulation. So they look at various labs or certain hormones within the not only just the urine but also like within the blood as well um, to see what that process is like. So usually during the ovulation period, a certain hormone called luteinizing hormone is usually elevating to a high extent, and it's elevating in a high extent because the process in which when the egg is undergoing has when the egg has been released, some of the coating ends up having to go it ends up releasing certain hormones that ends up helping in the preparation of the fertilization process. So if that's affected, that can affect the ability to have fertilization in the first place. So that's why they look at that. Again, thyroid disease is something that is overlooked, but it's something that is very very important to evaluate as well. As when you have a very very low thyroid function, you end up having really really heavy bleeding. Versus if you have a really really high thyroid function, it makes you it makes it really hard in terms of there's not much bleeding or menstruation that happens at all, and that's not good either. You need that coating or that lining for the fertilized egg to implant into. So if that's affected, that can also affect pregnancy. The next step that they look at is also they're looking at if there's any blockages, not only in just the fallopian tubes themselves, but also the actual uterus too. Blockages in any of those places can prevent not only just the sperm from reaching to the egg, but it can prevent the egg from reaching to the area from which the sperm could get to as well. In terms of the next things that we use to look at that is we usually have these tests or these imaging tests called, I don't know if many people have heard this, it's called a hysterosalpingogram. This is where they pretty much inject dye um, through the entering through the vagina into the cervix area, release the dye, which lights up not only just the uterus area but also the areas of the fallopian tubes, and they look for any spilling over throughout that process. And if there's no spilling, then that means there's a blockage. And then lastly, in select couples, you usually look at they can evaluate via ultrasound of the your pelvic region, just to see if there's like any cysts that are in the way, or also if there's any as we were talking about in the last lecture, fibroids that are large enough to cause issue. And then if in scenarios where there's a concern, say for example, if there is a concern for endometriosis, um, laparoscopy as well, if indicated, can allow you to see some of those various like tissues that are affecting your ability to have children. So next slide. So this is the hysterosalpingogram that I was trying to describe to you in a diagram format. Again, like when you look at the bottom, they insert a catheter like through the vagina to the cervix area, and they release like this lit up dye, which ends up traveling through and filling not only just the middle portion here, which is the uterus, but also these tubes that you see on the side of them as well, the fallopian tubes, and then like the little white looks like a Q-tip. It doesn't touch the ovaries, but if you see that dye spilling over towards there, that means that okay, there's no blockages there. And then that white part that you see on the right side of the picture, where you see the dye just stop, like right at the beginning part of that fallopian tube there, that means there's a blockage. Next slide. So how do we treat this? So again, it's all case by case basis. It all involves identifying not only just factors that are reversible as well. But in scenarios that are irreversible, we try to overcome those as well. The easiest thing that you can do is try to identify the reversible factors and try to treat those accordingly. For example, if one of the reasons why it's hard for you to have a child is because you have an undiagnosed and or uncontrolled thyroid disease, where your thyroid is too low, if you give somebody thyroid replacement, that will improve. If you have what we call polycystic ovarian syndrome, which is a condition where you end up producing a certain amount of hormones, which can make it hard for you to have regular menses and a whole list of other problems as well. There, you can give treatment to be able to treat that. And if you have things such as um, uh, really large fibroids, or if you have endometriosis, which is not responding to certain therapy, if there's any, you can try to image and or scope the actual reproductive areas to see if there's any scar tissue that you can remove. The biggest thing that can help to achieve or maximize the ability to have a child is lifestyle modification. These apply to every aspect of your life. And in the last part, what I was mentioning in regards to that, not only helps with blood pressure, not only helps with weight loss, but it also helps with your overall health. And so doing things like not smoking, reducing caffeine and alcohol intake, um, trying to obtain or meet certain weight loss goals. Usually they say a target of like 20 to 25, but just for the most part, if you're aiming towards like trying to lose getting under like 30 BMI, um, those are things that are very helpful in terms of achieving success. Um, in terms of the timing as well, there's a lot of planning that has to go about this process. So having what we call like time sets, like about maybe like 1 to 2 days, like every 1 to 2 days, like around the time where you're ovulating. And they even have tools now where they have an ovulating predictor as well, so they can you can kind of have an instance or indicator that you could be ovulating at this point to help maximize success there. In scenarios where these aren't these won't do the this won't work, and that there are other options that need to be explored, there are things that they can do to again maximize the ovulation piece, which is to induce the ovulation in the first place. In terms of treating patients who are not able to ovulate, there's drugs that we can use in order to treat those conditions. Some of these medications are what we call they call them clomiphene citrate. This is a drug, and letrozole. These are some of the drugs which pretty much work to um, block certain apparatus in your brain, which sends signals to your organs that produce certain hormones and certain uh, eggs, sperm, things like that, in order to have them continue to produce. Because everything in your body has an on switch, but it also has an off switch. And the presence of what your body is trying to make ends up becoming the off switch. So these medications help to stop that off switch, so you can maximize the amount of hormones you need and the amount of eggs and sperm you need. Next slide. So this is another option as well in terms of this helps to provide an assistance towards having that process of fertilization and implantation and pregnancy happen, but this in the setting of somewhat of like a test tube. So this is called assisted reproductive technology. Pretty much what they do is they're using uh, via scientific handling. They're taking the human egg, and they're taking the human sperm, and then they're trying to facilitate that fertilization piece, and then they take that fertilization or fertilized egg, and then they put it back into the uterus um, to hopefully it develop into a baby. Um, some of the things you've heard in regards to these types of technologies have been IVF or in vitro fertilization, which we'll talk about in the next slide. There are other things as well, such as like we call intrauterine insemination, where pretty much they take the person's sperm, they wash it, all the inflammatory pieces that would normally create like an allergic reaction in the uterus. They clean all that out. They concentrate it, and then they put it under. They inject it into like the actual person's uterus cavity through the cervix. So pretty much is the way of just kind of bypassing the coitus component. They'll just go straight to the cervix and then inject and like a cleansed or hypoallergenic sperm sample into the cervix and then into the uterus eventually. And then there's what we call intracytoplasmic sperm injection, where pretty much they bypass the part where the sperm has to like fuse into the egg, and what they do is they inject pretty much the sperm directly into the center of the egg where its nucleus is. So it kind of bypasses it having to swim, it having to find the egg, and then having to do all the fusion component.
A question for you on that. So is there like and it might be a silly question, but is there like a side effect or a or some type of faulty issue when you have to inject the sperm in rather than it coming naturally? So that's where I'm really going with it. Natural aspect to artificial. So it's not artificial, but it's like you assisting. Is there some type of impact or side effect that either will impact the mother, the child, or even as it impacts later on in life?
Yeah, so that's a really great question. So in terms of that process, like that process, though the benefits sound like, they it sounds like too good to be true. You have a higher chance of achieving pregnancy. There are some associated risks, especially that I'll talk about with in vitro fertilization. One, the process of going through this is it is a lot on the body. The second thing is that the actual process in itself, because you have like an increased risk of not risk, and because you have an increased amount of likelihood of having successful embryos. The issue is that they're using a lot. It's not like it's not a one injection to one egg and then you're done. They're usually using like a lot of several eggs that they're going through this process with in order to achieve success. But the issue is that what if a lot of them work? So then now you're going to have a scenario where you have an increased risk of having multiple gestations or multiple pregnancies in one pregnancy cycle. There's an increased risk of having low birth weight children. There's an increased risk of pregnancy complications like preeclampsia. And then to top that all off as well, from an outside aspect, it costs a lot to have a lot of these achieved.
All right. So, what is actually, and is that taken off? Should we make this another subject? Preeclampsia. Yeah. Like, what is preeclampsia?
That's a good question. So, preeclampsia is a pregnancy related disease in which is a combination of a lot of different things that are happening. The first thing is that it's usually defined as you having an elevated blood pressure of a certain amount after a certain amount of weeks gestation, usually about, say, 20 weeks gestation. It's usually coupled with a couple different things that we have to assess for as well, such as having protein in the urine or having what we call fluid retention in certain parts of your body as well. It can be either or of those connections there. The issue with preeclampsia in itself, and we can talk about it in another presentation if you guys also like that as well, is that they can lead to complications with the birth, because the actual vessels that are connecting both the mom to the baby, those can get affected, and it can create like early birth. It can create scenarios where if there's worsening of your preeclampsia as well, you can have other aspects as well that we don't want. Is that where you can have an increased risk of seizures, and which we call eclampsia, and there's a lot of things that are involved with preeclampsia, which is why they watch it heavily in obstetrics and gynecology. They have actually a whole division called maternal fetal medicine to manage those conditions as well. But that's a if that's like a long story short of what can happen, and not only just with preeclampsia, but also one of the complications is that as well. The last thing I wanted to talk to you about as well in terms of another complication that you can have, and this is as a result of stimulating so many eggs, is that you can have a scenario or complication called ovarian hyperstimulation syndrome. It's actually pretty life threatening and can cause a lot of discomfort as well. So these are things that you want to watch out for as well.
Next slide.
Yeah. So this is in vitro fertilization. So in vitro fertilization is again this is usually the most common form that is used in the umbrella of assisted reproduction technology. Pretty much what we're doing is outside of the body, we're trying to facilitate fertilization of both the sperm and the egg. Usually, what ends up happening is they do they try to stimulate the ovaries to produce eggs. Once they do that, then they do an egg retrieval. So they try to take the eggs, and then they put it into like also a test tube as well. Um, the not a test tube. They put it into like a petri dish. Then you have the sperm that is also collected as well. They fertilize it under the facilitation of the like within like a petri dish or a test tube, which is that's what the in vitro part is. Then after they take that those fertilized um, um, uh, eggs as well, they then uh, put that connection back through your into your uterus area to hope for, and hopefully there's some implantation that occurs, um, facilitating a successful pregnancy. Now the benefits are again like you have a higher chance of being able to achieve pregnancy. Usually, again, I told you before, like within the provided circumstances, ideal like is a 25% chance of an ability to the probability of having a child. Um, this increases it to like 40%. The other component is that in comparison to like what other things there is less invasive. And in terms of the biggest thing in regards to what are the barriers from both from a female aspect or from a male aspect to the fertility or infertility, it actually is able to overcome some of those things. So, for example, for a woman, if there's particular issues in regards to the actual tube, let's say the fallopian tubes are blocked, or they don't have enough eggs that they can make in order to facilitate fertilization. This can kind of overcome that by doing it for you. Now, the risk are is the not only just things that I was mentioning before in regards to you have a higher rate of um, multiple pregnancies in one pregnancy cycle, but there's also it's very costly. I looked at some of the pricing; it can range anywhere from like 15,000 to 30,000, like per cycle. Um, and you may need multiple cycles, so that's you can very well spend a lot of money in order to achieve this. The other thing is again you get the complications of having preeclampsia and like low, preterm children and low birth weight children. And then again that life threatening a, a there's a complication that's involved with trying to stimulate a lot of eggs within the ovary. and that's a phenomenon called ovarian hyperstimulation syndrome. I've had a case of this while I was like working one day, and it was attributed to in vitro fertilization. So it is something that is something to look at, but it is something that if you are able to follow up with your obstetrician and gynecologist as well as urogynecologist and those fields of doctors, these are things that they can try to help reduce or overcome. Next
So I
slide.
got a question. So have there been an increase over the years of some of the things that has prevented the infertility aspect of it, and hysterectomies? Have there been an increase in that over the years?
You're saying if there's been an increase in the amount of people having to use in vitro fertilization?
Yes.
Oh, so that's actually a good question. I honestly can't tell you the specific numbers attributed to like in vitro fertilization. I can only offer you like anecdotal experiences, and the from what I've been seeing, I have been seeing a like a pattern of it being an option for many couples. And some of them are of reproductive age, so they're not people that are necessarily having to be like 40 or over or 35 or older. Some of them are within our age range as well.
The reason why I was asking that is because if there is an increase, then and this stuff wasn't happening as much back in long time ago days. So then, what is the um, idea of the cause of this happening? Is it the foods that we're eating? Is it the fact that we're not as healthy as we were back in those days, et cetera, et cetera?
Yeah, so I would say like a lot of it is all like pretty like multifactorial in regard to like the awareness. Like the awareness may be different like now than what it was back then. So like back then maybe there and even now like there's a lot of barriers or connotations that are involved when people have trouble with having children. So some people may not even say anything regarding those scenarios. There is obviously a change within diets as well. The obesity epidemic or the scenario where as a nation, all of our weights are going up, which are leading to increased risk of complications in various disease, not just with pregnancy. That's one. And then the other thing is also too that again like and this is you never want to be in this scenario too is that getting a lot of the support and follow-ups like with your obstetrician and gynecologist, all the little things like they help in terms of providing some of these earlier detection, surveillance, and ability to make these changes. So for example, as I was saying before, something as little as giving someone um, thyroid medication for an underactive thyroid can help solve a lot of the issues that they may be having for what was making trouble for them to be able to have a child. So it's a combination of a lot of different things, but I wouldn't say that it was necessarily that it was less like back then. It was just that it was not as brought to our attention like back then
Okay,
as it is now.
got it. All right.
Yeah. So other options are, we call a donor egg pregnancy. So meaning that the person like donates like their egg. They do us something regarding the actual genetic material to be able to make it happen. And then obviously they put it with the sperm as well, and then they insert it so that way they can achieve a pregnancy. There's always options of adoption. Um, and there's also surgical methods where they actually can go in via a scope through the not through through the vagina, cervix, reaching to the fallopian tube area, uterus area, seeing if there's any like particular scarring, any like masses like fibroids present, or any scar tissue that may prevent like pregnancy, and try to remove those things. Next slide. So I wish I could tell you a little bit more about hysterectomy. However, hysterectomy itself is an actual like surgical removal like of the uterus. And usually there's like different indications on why they try to remove the uterus. The first thing to divide this removal of the uterus in is what we call total, subtotal, and then they call it also, there's a total with a bilateral, so salpingo oophorectomy, which is meaning that the ovaries get removed too. So usually, the common indications for having a hysterectomy are in scenarios where you have like really large cancer burden. So if you have cancer within the uterus, the ovaries, um, if you have it in uh, in the areas of your within the belly, what we call the peritoneum, that's space. Or if you have really bad if you have bad cervical cancer as well, that causes like really large bleeding. That can also cause you to be a hysterectomy could be a route. Now the if you have again like really large and or bleeding fibroids as well, which can make it really hard to live your life in terms of you having you can be so anemic to the point where you need a blood transfusion. Sometimes they offer hysterectomy as a curative option to be able to stop that significant bleeding attributed by the fibroid. If you have a condition called adenomyosis, which is again similar to as I was saying before, where you have with endometriosis, you have that similar lining within the inside of your uterus and outside areas of your uterus. In this scenario, you have that the same lining that would be present with inside the uterus in the muscle layer of the uterus. So this causes like significant pain, uh, abnormal contractions, and can cause inability, and it can cause a lot of miscarriages. A person who's known for struggling with adenomyosis is an actress named Gabrielle Union. Um, she's had a lot of her story trying to be able to achieve pregnancy and like undergoing a lot of miscarriages as a result of this condition that she didn't know that she had at the time. The other thing is sometimes you can have, for reasons that are unknown, just really abnormal uh, bleeding within the uterus, where the layer gets so thickened um, for either hormonal reasons or reasons out of our control, and it can cause a lot of bleeding also from that standpoint too. So in terms of when we're dealing with like hysterectomy as well, the biggest key thing to know is that once you get a hysterectomy, you cannot have children once you have a hysterectomy. So these are things to like weigh in as well in terms of when a hysterectomy discussion is had. It's also in the setting of what a person's reproductive goals are. Okay, so that's the end of my presentation. Are there any questions that you'd like me to answer?
So, well, I'll ask the audience, are there any questions? But um, I have a couple questions myself.
Mhm.
One is, so when there's a hysterectomy, does it impact the hormones the um, of the of the woman? So do they still have sex drive or sexual desires, or is it pleasurable to them, or are they just not in the mood anymore? They don't want to be bothered, or like, well, what are some of the common um, things that happen from this?
So I mean the issue is that I mean it can put you in the states of menopause because of the lack of the particular hormones that would normally be around during the time where if the uterus and the ovaries are present. But in regards to being able to like whether the person's like desire is affected and things like that, that's not necessarily the case. Now in terms of the comfortability during like sexual intercourse, that could pose as a barrier, but they also have medicines that are involved to kind of help that process too. Where if a person is experiencing, as say, attributed to menopause, let's say a dry vaginal canal or the actual the vagina itself is creating due to let's say the lack of hormones that would normally like stimulate the shape and morphology of the actual vagina itself. There are actually like creams that are like vaginal estrogen creams that can help with that process as well. But again, these have to be talked about with your provider as well, as depending on the scenario, not everybody is a candidate for those types of medications. In the scenario where a person say they have a hormone sensitive cancer, let's say within the in the endometrium, or they have like a particular like breast cancer and things like that. These are discussions you have to have with your provider in regards to the use of those medications, because those are not something that we would recommend. Um,
The next question is, so um, I was having a conversation with a doctor one day, and they didn't say this is factual. They just said that that evidence is suggesting that a lot of the cancers that might take place in the prostrate or vagina area could have been some type of result of like disease, sexually transmitted diseases that might have um, lodged there or got there, and just pretty much that per se. She was saying that evidence is starting to suggest, because a lot of times when they do autopsies on people, once they're dead, they do an autopsy on the various parts of the body that's cancer related in those particular areas. There were some type of uh, disease evidence, that sexually transmitted disease evidence that was in that particular region. So
no, so
with
yeah, go ahead. Sorry, no, finish your question. Sorry.
no, that was the question. Like, what are your thoughts? What do you think?
Oh no, so there's known like data on the associations of certain sexually transmitted infection, as you would say, or viruses towards uh, certain cancers. So, for example, people may have known about this as well. It's called the human papillomavirus, HPV.
Yes.
It's long been associated with some of the stereotypes of HPV are associated with cervical cancer, certain anal cancers, penile cancer. For in terms of with sexually transmitted diseases, like for example gonorrhea, chlamydia, syphilis, those are not necessarily associated with cancers per se, but they're more so associated with pelvic inflammatory diseases, which can affect fertility. So, for example, if you say you've had chlamydia, say unknowingly, and haven't had it treated or whatnot, it can lead to a pelvic inflammatory state, um, and can cause blockages. Not only just due to the inflammation, but also abscesses or infection can develop in those areas of your fallopian tubes, causing blockages, and that could affect your ability to have kids. So these are the known associations in regards to um, uh, not only just the cancers with the human papillomavirus, but also with certain sexually transmitted diseases, and why it's important to if you are sexually active, to test yourself, not test yourself, but get tested to make sure that you're getting adequately treated if that is that scenario. That's why they do the cervical cancer screenings as well, because when they're doing the cervical cancer screening, they're not only just assessing to see if they're seeing any abnormal cells present there, but they're also seeing if some of those have HPV as well, and if those particular types of HPV are cancer producing, so that way they can manage you accordingly. If that answers your question.
It does. It does. So you know what? This leads us to various topics that we probably talk in the future about. So we're gonna end this particular segment now. Is there anything else you wanted to share with us before we close out?
Yeah, I'll just say that like again, thank you for listening. I would say that in regards to the case of infertility, it's not something to necessarily be scared of or run away from. It's all about just getting the information to seeing like um what if there are any barriers or any obstacles towards making whatever goals you have be achieved. It's not to be discouraging. It's not to say anyone's capability or saying that someone is not a man or not a woman because of them not being able to achieve their goals in a way that they didn't know that they could achieve it. There are multiple methods to be able to make that one goal, which is for you to have a child. It doesn't matter how the person got into this world. The person is, as long as they're healthy, and as long as you can look them in the eyes and and be prepared to be a good parent. That's all we necessarily care about, and we want to help you to achieve those goals.
Hey, Dr. James, I wanted to thank you for taking the time, sharing your knowledge and your wisdom and experience. And we're looking to get you again next month sometime. We want to thank you. So as we're about to close out, I want to thank everybody for tuning in and watching. And by God's grace, we'll speak to you soon. Okay, be blessed, everyone.